I welcome you all for the second day of this cadaver workshop on cranial endoscopy. Yesterday, I would like to give a brief regarding what all we have done yesterday. Yesterday, we were able to cover all the basic techniques plus advanced techniques of access in sagittal plane. And Dr. Prakash Nair had very well demonstrated the extended techniques, first access to the cella and then extension into the transplanum area, transtuberculum area, and how to expose the cavernous sinus. Yesterday the demonstration was done, and we were very happy to see that most of the delegates were able to reach the targets which we had planned to get done from them as exercises. So I feel it was a successful day yesterday. Today, to start with, we have with us here Professor Rakesh Kumar sir. Sir is HOD ENT. Sir needs no introduction. He is a very well-renowned international and national personality in skull-base surgery, especially on the endoscopy side. To start with, sir, I invite sir for his talk on optic nerve sheath decompression, tips and tricks. Professor Rakesh Kumar sir. Thank you, sir.
Thank you, and good morning to all. A special thank for Professor Rajiv Sharma for calling me and sharing my thought on the optic nerve decompression. Probably it will be slightly different perspective from, as the neurosurgeon, they are much more dynamic and adventurous as compared to ENT surgeon. We are told to preserve whatever you can.
We have mixed crowd, sir. ENT surgeons and both are there.
Okay. So I will be just talking about how to do optic nerve decompression. What we usually get for optic nerve decompression are the patient who have acute post-traumatic visual loss. But not all traumatic visual loss are the cases for the surgical intervention. So what are the indications? So first is that you have to give steroid. So if there is serviceable vision is there, manage with the steroid, because whenever you do surgery, you always weigh the benefit versus risk. So the risk is much more than the benefit if there is a serviceable vision is there. If there is a severe visual loss and undisplaced fracture or probable fracture, there might be hematoma in the ethmoid or the sphenoid sinus, and if there is no improvement, or if there is a vision is going down after giving steroid over next 24 hours, then you can take a patient for surgery. If there is a severe visual loss with fractured bony chip which is impinging onto the optic nerve, again you can take up the case for surgery. If there is a complete visual loss with extensive fracture and nerve has been cut, it is a poor prognosis even with your surgery. If there is a chronic visual loss and perception of light is also absent, the prognosis is universally poor. You can still give a chance, provided that you counsel your patient well, tell them that we are only taking chance, you may or may not have improvement. Improvement, if it is there, it may be partial. Whenever you want to do optic nerve decompression, you have to have the proper workup. You involve the ophthalmologist as well as neurologist, get visual acuity and field charting. Intraocular pressure has to be checked, and do fundoscopy, what's the status of the fundus. Color charting, red color goes first. So that is the indication that your patient visual acuity is going down, and get the evoked response. Okay, it is something like ABR for vision. They do evoked potential, they check. If the amplitude is less than 2/3 of the normal side, and also there is a prolonged latency, that is an indication that the vision is going down. Get CT scan, HRCT in all three axis, like axial, corneal and sagittal. The approach to optic nerve You people are much more comfortable doing intracranial. One can do transorbital and the transnasal. So intracranial, whenever you have to expose the cranium for something else, along with that you can do. Transorbital, if there is a too much prolapse of the soft tissue into the nose, then obviously the transnasal may not be very feasible thing. For optic nerve decompression, what are the absolute requirement? The requirement is complete knowledge of anatomy of the sinuses as well as optic canal and the endoscopic surgical technique. So these are the opportunities where you can learn on the cadaver how to reach there, how to approach it. Anatomical aspect, the thick part is the optic canal, which is about a centimeter long, and it contains optic nerve, ophthalmic artery, and the sympathetic plexus. And this is on scan. If you see, this is lamina papyracea, medial rectus, lateral rectus, optic nerve, and this is the optic canal. This is the optic canal, okay, and this is the thickest part. And this is on coronal section. This is sphenoid. This is optic nerve. This is the anterior clinoid process. This is carotid bulge. This is that optico carotid recess. This is septum, which is attaching on to the optic nerve. Sometimes it will be attaching to the carotid. So already you must have learned that not to pull anything in this sphenoid sinus. The special instrument which is required is the drill, the endoscopic drill. Diamond is much more safer as compared to the cutting burr. The basic consideration, you have to give antibiotic. It depends. Suppose you have to do in acute onset, then obviously you don't have time. So it is not absolute necessary. Operate under general anesthesia, topical and injectable anesthetics. Beside the general anesthesia, you have to anesthetize the area wherever you will touch, plus decongest. Okay. People use pure adrenaline also, and the thinking is that when you use adrenaline, it causes the decongestant, so it will not absorb. Whereas if you talk to anesthesia, they will say, don't use it, maybe 1 ampule in 30 ml. So most of the time, like all surgeons do, you don't tell anesthetist, and you tell the sister, but sometimes sister will shout. You ask sister, get 3 ampules, give me 3 ampules, so everyone is listening. So that you have to ensure. The initial steps is, these are ethmoid cells, okay? So all ethmoidectomy has to be done so that you can delineate the lamina papyracea. The middle meatus antrostomy has to be done so that you can see the maxillary antrum. Why you need to see that? One is that it will ensure that you are at the right place where the lamina is. Once you open the ostia, middle meatus ostia of the maxillary sinus, the inferior and medial wall that is made by the lamina. Okay. Also remove the posterior fontanelle. The posterior wall of the maxillary sinus is correspond to the anterior wall of the sphenoid sinus. So that gives another clue where your sphenoid sinus is. And when you reach the sphenoid sinus, do wide sphenoidotomy. And one more practical point is, if it is posterior ethmoid, you will not see you will be able to see the floor. Only sphenoid sinus you will not see floor. If you are able to see floor, you be careful, this is not sphenoid, this is posterior ethmoid. And also, if you measure the distance from antennatal spine, you take your instrument, straight instrument, suction tip, It is roughly about 5.5 to 6 centimeter at 30 degree. So there is the sphenoid sinus. And also about 1 to 1.5 centimeter from the choana, the superior border of the choana, lies the sphenoid sinus opening. So there are multiple landmarks. Also sclerotinize the skull base and the lamina papyriaceae, which we talked. Identify the orbital apex in the posterior ethmoid and optic canal in the sphenoid sinus. Can you see this? This is sphenoid sinus and this is the optic canal. And then you start thinning the optic canal. Okay, so this part where the anterior face of the sphenoid is there is the thickest part. More often you will be able to take it off with the elevator, but not then you make it thin, axial thinning, and then you can take your elevator and break it into small pieces and take that out. Okay, and you have to expose till the nerves start turning medially. So that is the area where the optic nerve turns into optic chiasma, right? And expose it about at least 180 degree, right? Don't pull anything. You break it into small pieces and take them out. Because at time the carotid artery is only covered by the mucosa. So till the time mucosa is intact, you are safe. Incising the optic nerve sheath, if there is a hematoma you are suspecting, then you can incise. Incision has to be done in superior and medial aspect. Don't incise in the inferiorly, because there lies the ophthalmic artery. This is a small video. So the half of video is to decongest and expose. You put cotton wick under endoscopic control, because small area of bleeding will obscure your surgical field. Okay, this is middle turbinate, this is middle meatus, this is lateral wall, this is septum. This is on the right side. This is middle meatus. This is uncinate process. Can you see this? Anything which is visible is accessory ostia, not the natural ostia. Natural ostia you will never see. So taking bipolar cautery to cauterize the part of the turbinate. This, depending on how much space is there, you can excise fish mouth type, or you can leave it. So in this, partly it was removed. The anterior end of the middle turbinate better to preserve, because that will be important surgical landmark for subsequent surgery. So this is uncinectomy, sickle knife, incise it. You have to be careful there. Don't lateralize too much your knife, otherwise you will enter into the lamina papyriaceae. This is bullectomy. Okay, and then you open infromedially, right? So this looks sphenoid. Okay, so enlarge the sphenoid sinus opening. So this is the optic tubercle area, which is thick bone, and this is optic nerve. So part of lamina can be taken out with the elevator itself. And this is the bone which I was talking, quite thick. You can use the bone nibbler, bone punch. So use ample saline irrigation. That will help in clearing out your field, as well as bleeding is also controlled. And then you take out the small chips there. This is that carotid, this is that recess. And can you see now it start turning? So again, few more bony fragment which are being taken off. So rest of the mucosa is not touched much. So again a small further just taking out this, and this is what complete your exposure of the optic nerve. And then before you come out, you have to ensure if you want to excise, you excise at this point, and then you cover it with Surgicel and maybe some ointment. Don't put directly pack on your nerve, because when you pull the pack out after 48 or 72 hours, you may again traumatize facial nerve, especially if the sheath has been excised. So hemostatic pack, and also pack in the middle meatus to avoid that adhesion with the lateral wall. And pack is removed after 48 hours. High dose steroid has to be continued after surgery. And once the pack is out, you advise the normal saline irrigation to take out and wash all the debris and any crust. And nasal steroid for about 4 to 6 weeks till the time healing is there. You can do endoscopic suction cleaning of the nose as well. The video was from Dr. Prem Sagar, who is professor with our department. So with this I end my talk, and any question I will be happy to answer.
Thank you, sir. Very nice talk and very informative talk, sir. One question I have, is there any role of VEP in the patients who are having either severe vision loss or nearly complete vision loss? And does it help in, does it change any management, whatever information we get from VEP, does it change our perspective towards surgical planning?
VP means
visually evoked potentials.
Yeah, so that will tell you is the vision going down?
Mm-hmm.
Because what clinically you are seeing may not be very accurate. So visual evoked potential, when you do, if it is the amplitude is less than 2/3 of the normal side, it is the indication. If the latencies are increasing, again this is an indication. Beside that, the visual field charting will tell you earlier as compared to the seeing the visual acuity. So those are important investigation to decide about the surgery.
And regarding the patients who are selected for surgery, should it be done as an emergency procedure, like patient came and do it as soon as possible, or should we wait for routine notice?
If provided that what facilities are available, if proper facilities not there in emergency, then there is no point.
Okay.
If facilities is there, in ideal situation, don't wait too long, but it is not that dire emergency, the patient comes and immediately you shift.
Okay.
Okay, workup, scan is a must. Visual acuity, at least field charting you can do on the bedside, right? If the facilities are available, good anesthetic, hypotensive anesthesia you can get, you have all the instrument, you have drill and the expertise, then you can go ahead.
And regarding workup, is CT sufficient, or do we need any MRI also before planning surgery?
As an ENT surgeon, I am happy with CT. Even
okay.
MRI is there. You may get additional information with that. I know the neurosurgeons are much more comfortable with the MRI, and that can differentiate between the hematoma and inside what is happening in the optic nerve as such, which will not be shown on the CT scan.
Okay. And in cases where we open the sheath, optic nerve sheath, what is the possibility of CSF leak, and do we require lumbar drain in the cases where we open the sheath?
I don't think so, because if you see there's paper from PGI which says that you can create a window which is something like for eye glaucoma they do. So that say that it allow the continuous the drainage of this CSF in cases of increased intracranial pressure. Meningitis will not happen till the time the pressure is more inside the cranium. If it is negative pressure, that may create more issues.
No.
So it will not lead to CSF rhinorrhea. This will heal after some time.
Now most of these patients are lying in the ICU. They have got we can't check. Only ophthalmologist can check perception light or anything like. So how to decide how much vision he is having? It's difficult to take the patient to the OPD, eye OPD to check whether to do surgery
because
or not.
most of these patients will come either who have not have that severe injury, then they will end up into your emergency with maybe epistaxis, with some swelling of the eye. And then you realize that on get the CT scan, you get it. It is something like facial nerve injury. Okay, post-trauma facial nerve injury, no one will see, and patient comes after say third or fourth day from outside the ICU, then you realize. So it depends what you feel and what your the CT scan findings are.
No, so the clinical scenario, like patient have got small SDH or EDH, he's not intubated or anything, he can tell the answers.
Yeah.
Like ophthalmologist said PL is present only, or pupillary reflex is present. So whether I have to go for surgery immediately, or we have to start with the steroids. Like you said serviceable.
You start steroid and then you prepare for the decompression.
Okay. And nothing
right?
like
because it is one of the important sensation. So you can't leave it on chance.
Okay.
If it is like 7 days, 10 days, then probably you can get the fully investigated, and then you decide. If it is acute, less